palpate. You can palpate the sartorius. If you lift up your leg a little bit, then you can feel the rectus femoris, yeah, just inferior to the iliac spine. The TFL, if I was to roll my patient's leg in, let me do it. If I put my fingers like this and roll the leg in, then I can feel the TFL. You might find it easier if they do it, if you turn the leg in, because they will activate. Okay, and again, so you can feel the TFL. You can see like this muscle on the side that will kick in. So you might feel, so it gives you an idea. Maybe have a lie on your left side, facing that way. So from here, you've got the greater trochanter on the side. If you've got like maybe a bursitis, if you found that bone to come behind it a little bit and up a bit, and you've got pain in that area, then you think, well, what could it be? It could be that you've got a greater trochanteric bursa here. So if you find the greater trochanter, just come behind it a bit and up a bit, and come into this area. Be careful, because obviously the glutei comes in. But if that's where they complain of pain all the time when they're running, then maybe you've got a bursitis. Yeah, rather than a glute med strain. Yeah, that sort of thing. If you're not sure, you can turn the leg internally, externally, and you can feel the greater trochanter rotated. I'll line in front, please. So there's not really that much we palpate in the hip, because it's not really the hip as such. We're onto the femur. Yeah, we're onto the ASIS. So in terms of the hip, when you think about the hip itself, when you're onto the hip joint or the ball, we can't get to the ball, we can't get to the neck. We can't really get to the lesser trochanter. We can sort of feel the greater trochanter. But of all this with the socket, we can't really get too much of it. We've got the large ligaments that cross around the front, the iliofemoral ligament, the pubofemoral ligament, yeah, and then the ischiofemoral ligament. So you've got these three main ligaments here that will keep everything together. So it's covered by this massive ligament, so it's hard to palpate structures. This area, there's the socket, there's a connection between the socket and actually the head of the femur. So what would this implicate here? Is actually, can you see that dip? And we know the name of that dip? Not quite. No? Yeah. Damon? No, it's not foramen. Foramen is in the whole rather than a depression. The fovea capitis. Fovea, F-O-V-E-A, capitis. So it's like the capital, the fovea, so it probably relates to the dip. But, so it's not quite what it says. And there is a ligament which attaches. Name of the ligament?
Teres?
The teres ligament. What does teres mean? Round. Teres, ligamentum teres is round. It's round rather than flat because it carries an artery. So it's called the ligamentum teres. So it goes from the socket to the head. So it's unique to the hip and only to the hip joint. But we don't really know how much blood it supplies. They know that it supplies part of the head, yeah, around that sort of area. But you'd think it makes sense, wouldn't it? If you have a blood supply coming in, you'd think, well, that ligament supplies the head. The thing is, if you dislocate the hip, you tear it, and if you tear it, you lose the blood. So then maybe that might be a precursor for a necrosis. Not always, yeah, because it doesn't work like that. A necrosis is death of tissue. Think about a necrosis of a hip in a boy, what would that be called? David? 8 years old. That's one of the pathologies you might have to learn. I mentioned it yesterday, if you remember. Perfs. Yeah, Perfs. It's a TH. Yes. Named after who? Leg calf. Okay. Named after actually Arthur. Sounds weird. Arthur leg. Yeah. Jackie and George got the knee. Okay. Leg calf, Perfs disease. So Perfs disease is an avascular necrosis of the head of the femur. It forms a mushroom shaped, typically in boys between 8 and 12. Yeah, give or take, mainly. Why? Don't know. It's to do with blood supply. Yeah, so it's due to a lack of blood supply, or maybe a blood supply clots, thrombus, head of femur changes now, and then instead of forming like a ball, it forms like a mushroom shaped. But then that boy might present with knee pain. So if a 10-year-old boy comes in and says, my knee hurts, I'll probably get them to x-ray the hip joint to look for the Perfs disease. So you might find you don't get symptoms, no symptoms, you're asymptomatic, but the knee is symptomatic. It's not always good slatter because they're not old enough to get it yet. Okay? So be careful with that one. So you can't really palpate that much in that area. If you think about my friend who had this pain in her, lay down please. So week 1, ischial tuberosity, excuse my thumb. Okay, so ischial tuberosity, where the hamstring attaches, slowly bring your heel up, or bend your knee, I mean. So you can feel the contraction. So when you think about it, bicep femoris becomes the sacrotuberous ligament, relax. My spine, let's use this one. Excuse me. Ischial tuberosity, bicep femoris, sacrotuberous, sacrum, tubercle or tuberosity, it comes in here. And then the bicep femoris becomes that ligament. Rather than stop in and continue in. Yeah, so it continues. And according to Myers, it goes up the same side. And Vleeman, Andre Vleeman, the sling goes up on the opposite side. Okay, so it comes from bicep femoris, peroneal, tibialis anterior. So it continues up. So it continues up. So that ligament basically keeps the sacrum into a nutated position. If the sacrum is nutated, we have natural tension on that ligament. If that ligament has gone back, as in counter-nutated, and that ligament is relatively lax, so it's unstable. So the stable position is where the pelvis is tilted, where your heart is slightly nutated. So that would be the better position. So my patient was having pain in the hamstring area, sacrotuberous ligament, and even in his foramen here. This is the greater sciatic foramen, because the sciatic nerve will penetrate from L4, L5, S1 and 2, and it will go through the foramen and off it goes down the leg. And if you look at this one, excuse me, that's okay, I can do it there. If you're looking at this one, you can see the sciatic nerve, the yellow, the greater trochanter. The sacrotuberous ligament where the bicep femoris continues, there. Piriformis, and then you got the deep rotators. So the sciatic nerve potentially goes under, on 1 in 5, so they say, it goes through. A friend of mine, she's doing a PhD on the sciatic nerve and piriformis. As in, that's it. Yeah, so she's done, so she could talk for a day or 2 or 3. Yeah, just on that. I probably would give in after 1 hour. Yeah, I said if we move on to something else. Yeah, I would, yeah. Once she's answered those questions, but okay, let's move on. But that's what she was doing. So she says, well, and yeah, I said, does it go through or not? She said, well, I said, yeah, it goes through, yeah, in some, and that'll be enough for me. If it does go through, then maybe you might get sciatic sort of pain, but it does go through that sort of area. So she was getting pain. When you think about where her pain was, her problem was in the labrum in here, but her symptoms was there. So can you see it's relatively close, isn't it? Mm-hmm. But almost to a point, I'd put my finger on it, she'd be like, oh my God, that's exactly where it is. The same again, oh my God, that's exactly where it is. Yeah, you're on it, I said it, you're on it. And the same there. So I mean, it's hard then to take your thumb off, isn't it? Because she's almost expecting you to treat where it's hurt in. Even though it's all referring symptoms coming out. Strangely, I had a lady last week, she came from Leicester to see me. And she'd had ridiculous amount of treatments. She'd had sclerosis to her ligaments of her spine. Now she'd had a fall 14 years ago. And she had her pain is basically around the sacral part here. But she's had it, she can't sit for long, she can't drive. But it's affecting everything, she can't go on holiday because she's worried about the plane and sit in and da-da-da-da-da. But they've done loads of things. They've done nerve blocking. She's had loads of scans, no one's looked at the hip. And she's had an injection into that area of steroid, just into the area of pain, and it's made no difference at all. So she had sclerosis to her ligaments, no difference. Yeah, she'd had loads of things. But now they're talking about, they said, well, we think it's a trigger point, and we are recommending that the surgeon excises the trigger point. That's what the surgeon is talking about next, as in cutting it out. Like, don't be... Trigger point in that area. So they're not really sure. They're not really sure. They're almost giving up on why she's got the pain. Make a space. And I'm saying, if I was you, I'd have a routine steroid within the hip to see if it reduces the pain in that sort of area. That's my thought process.
You can't tell a doctor that because they're very nerds now.
Yeah. Well, I probably can. Yeah, in some ways.
You could.
Yeah. Yeah, so how about I'm saying whatever you do not go down the road of getting them to cut out. You haven't sugar corn because it won't make any difference at all. But this is because they've given up now. What can we do next? Yeah, but it just honestly the history is ridiculous in terms of what she's had done, but no one's dealt with it. So I'm saying, well, I think it's a big problem, and you know what I mean. So we're in that sort of process. But maybe steroids, have it private, and just see if it takes, if it takes away your symptoms, and you can sit, and then you go on holiday and have your life back. Then,
Should they at least do an MRI then?
No, because they don't think it is. They've done scans.